I'm Dr. Ken Landau. This is Well Now Doctor. Thanks for watching. We'll continue our discussion of vitamin D and vitamin D metabolism. We've already said that vitamin D is very important, obviously, but vitamin D is actually in the family of hormones rather than vitamins. We've also said that there's a lot of talk about how low the level of vitamin D is in the system these days, how many people are vitamin D deficient. The number of vitamin D deficient individuals probably, at least according to the current estimates, is somewhere between 50 and 100%. That's absolutely ridiculous. It's said that vitamin D is the sunshine vitamin, yet we know when we analyze people, the Maasai of Kenya and Tanzania, when we evaluate people in Saudi Arabia, when we evaluate people in the United Arab Emirates, when we evaluate people in Australia, an area with the highest skin cancer incidence in the world, we find that overwhelmingly they're vitamin D deficient, at least according to the current guidelines. So right away we say that there's something that just simply doesn't compute. And we've also said that vitamin D is the vitamin that helps protect the bones. So if we analyze people and they have low levels of vitamin D, theoretically they should be breaking their bones just left and right. On the other hand, when we evaluate people who have low levels of vitamin D, we find that African Americans and Hispanics have relatively low levels, even lower than the Caucasian population, yet the people with the lowest levels of vitamin D are the ones who seem to be least likely to have fractures. So what do we know? We know that at least there's a major part of the story that doesn't seem to make any sense, and it has to do with the laboratory test. And we'll talk about the laboratory test down the road, but we can say that at least what we're measuring now doesn't seem to make any difference. It's not an important chemical, at least as far as your true vitamin D metabolism is concerned. We've also said that overwhelmingly, the amount of vitamin D in your system seems to be controlled by certain genetic factors. And you can pour a lot of vitamin D into your system, and you're not going to change those genetic factors. And we know actually that the vitamin D that you take, that you consume either in a pill form, or that you consume because you're eating a lot of salmon or you're having a lot of other foods that are fortified with vitamin D, we know that that's not an active form of vitamin D. We know that the kind of vitamin D that you take by mouth has to get absorbed into the system, and whether it comes from the sun impacting on the skin or whether it comes from dietary purposes, it has to go first to the liver. When it goes to the liver, it's activated on by a chemical, and in the liver, that chemical takes the vitamin D that's inactive. The vitamin D that you consume isn't going to do anything. That vitamin D is changed, altered, metabolized in the liver, and it's made into a chemical that we call 25-hydroxy-vitamin D. Now, that's the chemical that's analyzed when you go to the laboratory and give your blood. But that's not an active form of vitamin D. That's biologically inactive. It's not going to do much of anything. We know that the vitamin D that's manufactured in the liver, which requires certain kind of enzymes, certain kind of chemicals that are going to be passed from mother, father to you. That's why you can't change your metabolism very much. So now you've partially activated, or you've done something to the vitamin D in the liver. Now it has to go to the kidney. It's going to go to the kidney by the bloodstream, by way of the bloodstream. It's going to get filtered, and then it's going to get altered by another chemical in the liver, different kind of an enzyme, and it's now going to be called 1,25-dihydroxy vitamin D. That's the active form of vitamin D. That's the kind of vitamin D that's going to act on your bones. That's the kind of vitamin D, theoretically, that's going to act in other areas of the body, supposedly, according to some people, to help impact upon the likelihood that you're going to get cancer of the breast, cancer of the colon, you're going to have heart disease, your likelihood of developing some other kind of a condition. But that's a different story. That's a completely different story. And as a matter of fact, at least at the present time, that story is maybe fantasy. But we know that once the vitamin D is activated in the kidney to this form that we call the 1,25-dihydroxy vitamin D, then it can do something. It has a hormone-like action. it's going to act because it binds to an area around the nucleus of the cell. And when it does that, then it can start doing something. Now, we have to realize that the vitamin D itself, the kind that's in your diet or the kind that you manufacture in your skin, that's going to float around in the bloodstream for a relatively long period of time. That's going to be around for somewhere around 2 months in the body at least. We know, on the other hand, that the vitamin D that's manufactured in the liver, that's only going to be around for about 2 weeks, maybe 3 weeks tops. We know that the kind of vitamin D that's manufactured in the kidney, that's the real important kind of vitamin D, the 1,25-dihydroxy vitamin D, that's only going to stay around for a few hours, up to maybe about 15 hours. Now, we know that that the level of vitamin D that we measure is the 25-hydroxy form. That's the kind that comes out of the liver. Now, you have to realize that our test is only a biomarker. This is important, a biomarker of exposure. It just tells us how much vitamin D you've been exposed to. It doesn't tell us that it's going to do anything. It doesn't tell us that it's going to be very important at all. It is not a biomarker. It's not a test of the effectiveness of the vitamin D inside your system. Doesn't indicate how much vitamin D is sitting in your fat. Doesn't indicate how much vitamin D is stored in your fat. Doesn't amount to a hill of beans as far as the amount that's going to be released over the course of the winter. And as a matter of fact, when it's released over the course of the winter, it's very important to realize that the vitamin D that's been stored because you've been out in the sun in the summertime, by the end of the year, by around November, December, it's exhausted, so you don't have any more stores of the vitamin D. And we know if you don't have enough of the vitamin D, if you don't have enough of the active form of vitamin D, you're going to have some problems. You're going to have problems because you're going to have an increased amount of bone loss. You're going to have an increased amount of fractures. You're going to have major problems. So you have to have enough vitamin D. But for the most part, the vitamin D that you're going to have is going to be dictated by your genes, because the vitamin D, once it's in your system, is not the active form. So we know that the amount of vitamin D that your kidney makes is only about 1/1000th of the concentration of the vitamin D that your liver is going to make, the kind that we're going to find when we do the assays. And it's very important to realize that the vitamin D, the active form of vitamin D, the form of vitamin D that's manufactured in the kidney, not the kind from your liver, not the kind from your skin, but the kind from your kidney, the active form, well, that's going to be regulated not only by your genes, so you can take an awful lot of vitamin D, and if you take an awful lot of vitamin D, chances are overwhelming that it's not going to do you any good, because it's kind of like looking at a funnel. You can pour an awful lot in the funnel on the top, but when you look at the amount that comes out, it's not going to come out more if you have the funnel completely filled or just a little bit filled. Doesn't make any difference, because that is the spot that determines your level of active vitamin D. And we know that not only do we have all of these genes that are impacting on it, the gene in the skin, the gene in the liver, the gene in the kidney, but now in addition to that, and also, by the way, the gene that happens to be carrying the vitamin D around in your system, but now on top of all of that, we have interaction of a variety of substances in the kidney itself that's going to determine what the level of that 1,25-dihydroxy vitamin D happens to be. So we know that the parathyroid level is going to help determine the amount of calcium that happens to be in your serum, the amount of plasma that happens to be in your serum. These are determinants of how much 1,25-dihydroxy vitamin D your body wants and how much it's going to produce. And by the same token, if you have the production, it can be shut off by certain kind of chemicals coming from some of the cells that break down the bone. We call those the osteoclasts. It can be decreased in number or decreased in amount by the phosphorus that happens to be in your system. So we know that there's an awful lot of complicated biochemistry that goes on as far as vitamin D is concerned, and as a matter of fact, it doesn't simply relate to popping a pill or eating a salmon. That's only a little bit of the story. Now, we also know that it's important to realize that the vitamin D and its carrier is going to go to a receptor. And the receptor could be on the bone cell. And it's in that bone cell where we can get the change in the genes that lead to some other kind of a function. We know that the active form of vitamin D, that 125 dihydroxyvitamin D, very short half-life only in the matter of hours. So the circulation amount isn't a very good level of how much vitamin D you have in your system. Instead, we pick this 25-hydroxy. And as a matter of fact, we know that there isn't really a good correlation between the 25-hydroxy vitamin D that's made in the liver and the amount of the 125 that's made in the kidney. So just going back to our funnel, we know that you can have just a little bit in the funnel, but if there's enough so that it's coming out the end, that's just as good as far as the amount that you're getting as having the whole funnel filled. And the same thing with the vitamin D. So it would appear that you can have a very low level of vitamin D in your system, and still, as long as you're manufacturing sufficient amount of the 125 dihydroxy vitamin D, as long as there's enough of that around, then you're okay. That doesn't seem to make any difference. And how do we know that you have enough? Well, we can certainly test to see how your bones are. We can see that the level of parathyroid hormone is okay. We can test to see that the amount of calcium in your system or the amount of phosphorus in your system is okay. And as long as we know that, then we can say that chances are you're getting enough of the vitamin D, or the active form of vitamin D. Now, what are the effects of this 125 dihydroxy vitamin D? What are the effects of this active form of vitamin D? Well, it directly or indirectly controls well in excess of 200 genes. Some people would say as many as 2,000 genes. Certainly, we know that it keeps the calcium and keeps the phosphorus in the correct amount. It keeps it in the correct amount because it changes the absorption from the dietary system, the duodenum and the jejunum principally. It also controls the amount of calcium that's going out in the urine. It also controls the amount of calcium that's going to be either put into the bone or taken out of the bone. If your calcium level is too low in your bloodstream, well, that chemical, the dihydroxy vitamin D3, is going to be very important as far as taking the calcium from your bone and putting it into your blood so you don't have tetany. We also know that there are a variety of other genes and metabolic functions that the active form of vitamin D is going to be associated with. We also know that if we look hard enough, we can say that there are some functions outside of the bone. And there's no question that the vitamin D, certainly in the laboratory and maybe in the human, can have some role as far as non-bone items are concerned. So what do I mean by that? Well, it can interact with cancer cells, theoretically. It can interact with normal cell production. It can interact with cell differentiation. So for synthetic kinds of vitamin D, we know that it can affect the skin cell proliferation. Well, we know that vitamin D is a form of therapy that we use for control of psoriasis to help the cells mature, or to help some of those cells die when we would like them to die. Something controlling what we call apoptosis. And it seems that it can act as an immunomodulator. It can control the immune system. And it can control the macrophages and the monocytes. Those are cells that are important in surveillance of the body. And we know that if we go far enough afield those macrophages are important in control of tuberculosis. And if we look at those individuals who are deficient in the vitamin D, the active form of vitamin D, well, there might be, at least in the laboratory, some idea that those people might have worse tuberculosis than the people who have normal levels of vitamin D. Is that really important? Well, no, probably not really, but that's what some people say. And there's a chemical called campholycidin that's made in the skin that helps kill some of the bacterial organisms. And it seems that at least somehow the vitamin D is important in the metabolism of that substance. And it's important in the control of the blood pressure and the amount of renin that you make and the amount of insulin that you make. And it's important as far as the heart muscle contractility is concerned. And it can be an anti-inflammatory substance, an antioxidant substance. It is important theoretically as far as the neuromuscular function is concerned. It controls the nerves and it controls the muscles. It controls nerves transmission. It can control the secretion of certain kinds of hormones. It regulates gene transcription. We know that it's a complicated story on how it interacts with the genes, but it interacts with another chemical known, the active form of vitamin D, interacts with another chemical known as a retinoic acid X receptor, and those two respond or get into the gene to the vitamin D response element, and the vitamin D response element then is important in controlling certain transcription factors, and they're important in controlling the gene function. So very important subjects, of course, but how much they really impact upon the nature of the situation that we're talking about, your vitamin D metabolism in your bones, and does it really make any difference as far as all of these other things are concerned, the tuberculosis or the heart or the cancer? Absolutely not. It doesn't appear that it's very important, at least in those cases, at least at the present time. We have much more information about the bone. And if we talk about things in general with vitamin D, we can say that at least there's the potential for the vitamin D interacting with a whole bunch of other areas of the body. Because remember we said that those vitamin D receptors are present in cells throughout the body, and the ability of some of those tissues to manufacture the active form of the vitamin D, the same kind of enzyme that's present in the kidney, are present in a variety of other tissues, including those monocytes and macrophages, including the pancreatic cells, including the colon cells, including the skin cells and the brain cells. So we can't completely discount the idea that the vitamin D is important in metabolism of those tissues. We just don't have any good evidence that it is at the present time. And after all, we kind of like to stick with the evidence, because a lot of the talk, a lot of what people suggest turns out absolutely not to be the case. But we do know that if we just look at the vitamin D receptors, or the ability of the vitamin D to affect genes in the white blood cells, just the white blood cells, it seems like the vitamin D might be able to interact with almost 300 different genes inside the white blood cells. And we know that there are at least 80 pathways that we know about in autoimmune diseases and cancer and heart disease that might have something to do with the story. But the real important story is still limited to the bone. And that's very important. It is the bone. And we would like the bones to be their maximal thickness. And you get the maximal thickness of the bone for a variety of reasons, but unfortunately it seems that our genes are going to significantly impact on the ability of the bones to grow. So if your mother has osteoporosis, if your grandmother has osteoporosis, and those people probably were out doing much more physical labor than you, because over a period of generations, we know that there's considerably less work, and we know that the more work you do, the more physical activities you engage in, the more you walk to school, the more you go out and run on the treadmill, the more you go and run to school, you play the tennis, you go do those sorts of things, that we tend to do less nowadays. Well, that's how you get harder bones. And that's absolutely what you want to do. So, what is the role of the vitamin D? Well, one of the roles of the vitamin D, the active form of vitamin D, is to get the calcium that you consume, get it out of your intestine and into your bloodstream. Can you do that without the vitamin D, without the active vitamin D? Sure you can. But it's only about 10 or 15% of the calcium in your diet that's going to be absorbed. On the other hand, if you have adequate amounts of vitamin D floating around, then you're going to absorb somewhere between about 30 and 40%. So you can double or triple your absorption of calcium simply by having adequate amounts of vitamin D around. So vitamin D is important as far as getting the calcium in the system. And as a matter of fact, you need phosphorus too. And under normal circumstances, without any of the levels of the vitamin D, when you're deficient in vitamin D, you're only going to absorb about 30-40% of the phosphorus floating around in the system. On the other hand, if you have enough vitamin D, well, you can absorb probably somewhere between 60 and 80% of all of the phosphorus that you consume. Now, it's important to realize that not only can you have too little of the vitamin D, but theoretically you could have too much vitamin D. You could have levels that are going to increase the calcium significantly in the bloodstream and increase the phosphorus. You're going to have a decrease in that chemical that we call the parathyroid hormone. You're going to have some toxicity, maybe because of some abnormality in the kidney. You're going to get a relatively increased level of kidney stones. And we know that you could get some other kind of symptoms. You could get symptoms like anorexia or weight loss or excessive urination. We call it polyuria. You can have some heartbeat irregularities, and you can have some calcification of vascular structures in your body, vascular structures in the heart and the blood vessels, and you can have kidney damage and all of that if you happen to get too much vitamin D. So you walk a fine line. You hear all of these reports telling you to go and get some more vitamin D, but you have to realize that you could get too much vitamin D, and you don't want to do that. Now, let's go back and look at some of the important concepts with regard to vitamin D, let's say in the sun. Well, we know that when we look at how much vitamin D you're going to be required to get for normal function, we call it the RDA, how much you need. Well, they've sort of completely discounted the amount of vitamin D that's going to be manufactured through your skin. So that's completely out. Now, interestingly, we know that the vitamin D that you get through your skin is probably a better source of vitamin D than the vitamin D that you get through your system, through your intestine. And we know that the skin has really great ability to manufacture the vitamin D. So if we look at what happens if you go out in the summertime, we're talking about summertime, because remember, we talked about it a few moments ago, the concept that you can't get the vitamin D in the wintertime. You can't get the vitamin D manufactured actually if you go out at 5 o'clock in the afternoon. There's not going to be enough of the ultraviolet A, ultraviolet B, there's hardly going to be any of it. But if you go out in your swimming suit in the middle of the day, in the middle of the summer, and you get what we call 1 MED, that's the minimal erythema dose. So that's the amount of sun that would cause you to get slightly pink 24 hours after you've been in the sun. Well, if you're in your swimming suit, that's going to be the equivalent of 20,000 units of vitamin D. That would take you probably about 20 or 30 minutes of sun exposure in the middle of the summertime. Now, we know that if you go out for a shorter period of time, you won't get burned, and you'll still manufacture a significant amount of the vitamin D. So we know that if you spend maybe 20 minutes, 15 minutes, 10 minutes outside, that probably is going to be enough. And as a matter of fact, if you go outside and you are wearing shorts and a short sleeve shirt, chances are if you do that twice a week, 3 times a week, chances are you're going to get sufficient amount of vitamin D manufactured. We know that the amount of vitamin D manufactured if you get sun to your face, well, you're going to get wrinkles and you're going to get skin cancers, but you're not going to get any vitamin D. So that's a significant issue. And we know that if we look at, say, doubling the amount of sun that we get, that might be sufficient to carry us through. On the other hand, there are people who say that you should go out and you should get sun and you shouldn't worry about putting the sunscreen on. Well, we've already said that Those are the kind of people who make comments that don't seem to make any sense. Comments like you could have 400,000 fewer deaths overall in the United States if we simply get more sun exposure. That's absolute nonsense. It's nonsense. If we look at the sun, we know that it can probably increase the amount of vitamin D in your system by maybe somewhere around 6 or 10 or even up to 15 nanograms. That's a significant amount, especially because we're considering a normal level at somewhere over 20. Well, if we can increase the amount of sun that you get, and it seems like women get more sun than men, and it seems like women, especially in the United Kingdom, going to have maybe the potential of a little higher level of vitamin D in the system. We know that the sun can have a significant role, but the role is being touted far in excess of what reality suggests. So, for instance, they say the closer to the equator you get, the more sun you get. Okay, that seems to make sense. But how about if you're in Canada and you're up in northern Canada and you happen to be there in the summertime? Did you know that the sunlight is going to come through about 24 hours a day and that there's going to be more ultraviolet B that impacts on the Earth up in northern Canada than there is around the equator? And as a matter of fact, if we look at surfers in Hawaii who spend at least 15 hours, not 10 or 15 minutes, but spend at least 15 hours a week out in the sun in the summertime surfing in their swimming suits, that those people still, many of them, have as low a level as 11 nanograms of the vitamin D in the system. Well, how can that be? So let's just say that this whole preoccupation with going in the sun to get your vitamin D is absolutely absurd. Now, there's no vitamin D that's going to be manufactured in the skin. In the wintertime, there's no UVB that's going to be present early in the morning, late in the afternoon, if you have a lot of ozone, if you have a lot of pollution. If you happen to be sitting where there's window glass, theoretically, we know that the ultraviolet's not going to go through those window glasses, through the car glass, through the glass in your office or in your home. Certainly not going to be the UVB that makes the vitamin D. So that's an important concept. We also know that it's very important to consider that if you put the sunscreen on, the sunscreen is going to basically completely block the ultraviolet B. That's when you get a sunscreen and it says SPF 20, SPF 8, SPF 5. That's all going to block the UVB hitting the skin. On the other hand, you don't use it appropriately. We know it only lasts on the skin for about 2 hours. So women who put the makeup on, who think that that's going to be sufficient to block the ultraviolet light, incorrect. And as a matter of fact, the sun's rays, the damaging rays, but not the helpful rays, going to come through all day long. So you're still going to get messed up. Your skin is still going to get older, but you're not going to get any vitamin D. We also know that the story of tanning. Well, they say if you go to tanning beds, that's bad. Well, we have the people who are pushing the vitamin D story, and they say, no. If you go to the tanning beds, even though the tanning beds contain mostly the UVA, they do have about 2 to 6% of the light that's emitted that's going to be in the UVB family. And that UVB family is going to be able to increase the amount of vitamin D in your system. So at least there's maybe a little teeny-weeny justification for going in a tanning bed, especially if you happen to have some sort of intestinal condition. Remember we said that if you have celiac disease, or if you have gluten sensitivity, or if you have problems because of regional enteritis, Crohn's disease, that you won't be able to absorb the vitamin D. Well, we know that the vitamin D from sun exposure to the skin doesn't have anything to do with the other ways of absorbing the vitamin D, so you don't have to have an intact intestinal system. And as we've already said, that by the end of winter, the overwhelming majority of people in the United States going to be vitamin D deficient. Now, let's talk a little bit about food. And we know that it's important to get the vitamin D, for the most part, through either supplements or through diet. But the levels that we talk about are a significant underestimate. So when you see that the milk contains this amount, or the other kind of food substances you contain certain amount of vitamin D, that's all the vitamin D2 or the vitamin D3, not the 25-hydroxy. That's not measured. Yet we do know that there's a fair amount of the 25-hydroxy vitamin D that will be in our food, and that is somewhere around 5-fold more active than the vitamin D that's labeled on your foods. So we know that there's going to be considerable confusion about how much vitamin D you really are getting. Now, fortified foods, an interesting story. There was fortification that was voluntary in the early 1920s, mandatory 1932, in that neighborhood. We know that milk supposedly has about 100 units per serving per 8 ounces here in the United States. So that means in a quart of milk, if you consume a quart of milk, you could get probably somewhere around 440 units. And that can be sufficient enough to increase the amount of vitamin D in your system, at least the way we measure it. If you take in 100 units, that would increase your level by about 1 nanogram. Now, it all depends on what your level of vitamin D is to begin with. If it's very low, that same 100 units could increase your level of vitamin D by maybe about 2 or 3 nanograms. On the other hand, if you have a lot of vitamin D in your system already, then it's not going to be so important. Well, the amount that we get in the food is relatively small because we tend not to have an awful lot of milk. We're not drinking a lot of milk. We're not drinking a lot of we're not consuming a lot of fortified foods. We don't have all that much. As far as margarine is concerned, in the United States, fortification is still mandatory for liquid milk, not necessarily for some of the milk solids. We know in Europe, there's not so much push for fortification. That has to do with the 1950s, when in Great Britain, there were some neonates, some newborns, who had high levels of serum calcium, and they couldn't figure out why, but they assumed that it was because the food was fortified, so they cut out the milk fortification. We also know that there's a problem with fortification. We know that up until relatively recently, and perhaps even recently in certain jurisdictions, that even though the milk was supposed to contain 100 units per 8 ounces, or 400 units per quart, that as recently as 15 years ago, well, it seemed like maybe only 20% of the milk contained that level. More recently, maybe about 50 to 70%. A study in New York looked at the milk in 2001 and found only 50% of the milk contained the adequate amount of supplements. But now, supposedly, it's better. Supposedly, a quart of milk contains about 400 to 600 units, and that's probably a pretty good idea. As we've said, there are certain kind of foods that are probably considerably underrated as far as the vitamin D is concerned, even though we talk about vitamin D present in milk and in orange juice. And by the way, for the most part, except for the milk, it's voluntary. And supplementation, fortification of orange juice and other kind of products, your breakfast cereals, that's voluntary. That's done for marketing purposes. But when we talk about the 25-hydroxy vitamin D, that's not measured. That's not considered when we talk about how much vitamin D is in your food. And as we've also said, that the activity of the 25-hydroxy vitamin D, that's the kind that's sort of made by the liver, that's actually 5-fold more potent than the kind that's made by the skin or consumed in your diet. And we know that there's a significant amount of that present in beef and in pork and in chicken and in turkey and in eggs. So something to consider. Another reason why we're probably not nearly as deficient as people suggest. In the United States, about a third of the people are going to consume supplements. But the question is, if you consume a vitamin D supplement, is there evidence to suggest that it's going to help your bones? After all, that's what you're taking it for, isn't it? You want to have healthy bones, so you go and you take your vitamin D. Guess what? There's no evidence to date, no evidence, no incontrovertible evidence that vitamin D supplements are going to make your bones thicker. Now, if you take some vitamin D and some calcium, maybe there's little evidence, but certainly vitamin D by itself, Does it make any difference, by the way, whether you take a supplement that contains the vitamin D2 or the D3? No, it doesn't really make any difference. So what happens if you don't have enough vitamin D? Well, the whole story began with a consideration of what we now call rickets. And rickets has to do with a deficiency in youth, in childhood, of vitamin D or calcium. And as a matter of fact, actually most of the rickets in the United States has to do with a lack of calcium, not with a lack of vitamin D. So we know that the story of vitamin D, getting back to that, comes from a time when people weren't getting enough of the sunshine vitamin. Now, in the old days, before we knew about the supplementation, before we knew about the fortification of foods, the only way you would get your vitamin D was basically through the sun. So what happened? Well, unfortunately, in the old days, we had children growing up in crowded cities, in squalor, and this goes back even to here in the United States, in the Industrial Revolution, back in the late 1800s, early 1900s, the cities were crammed, the air was lousy, kids didn't get any sun, and as a result, they got rickets. And we know that in order for the cartilage to lay down bone, to lay down adequate amounts of bone, to mineralize that bone, we need to have vitamin D. So vitamin D is very important, at least in appropriate amounts. Now, it was first described as a disease back in the 1650s by Francis Glisson, and he identified what was thought of as a new disease, but it really didn't come to anyone's attention, really, until the late 1800s, 1880s or thereabout, with the Industrial Revolution, when it was found that somewhere between 40 and 60, or maybe even as high as 80 or 90% of the children growing in cities, in urban areas, not rural areas, but just urban areas, had rickets. And that was a horrible situation. Nobody knew exactly what the story was, but around the same time, in the early 1800s, Dr. Sniadecki, he was first to realize that we got to get the kids in the sun. If you get the kids in the sun, they don't get rickets. And it was found that even in the squalor of areas of Asia and India, there was no rickets. The people were outside. The people were in the sun. But in the areas of London, in the areas of Glasgow, there was significant incidence of rickets, like I say, 50, 60, 70, 80%. Well, it was found in the late 1880s that if you get the kids from London and from Glasgow, if you get them at a relatively early age, prior to going through puberty, you get them in the sun, then you can erase a lot of the damage. It was found that in 1919, that if you expose some of these kids to artificial lamps, the mercury arc lamps that were used in those days, you could get radiological healing. And it was found in the early 1920s that if a child had rickets and you took the child up to the top of the hospital, put them on a hospital roof, that you would cure the rickets. And that was very important because up until that time, doctors thought, nah, there's no way that getting sun is going to do something to your bones. But then it was found in the early 1920s that that was indeed the case. Now, going back a little bit, it's important to realize that certain areas, remember what we said at the start of the first show, we said that when we were talking about Northern Europe, there's less in the way of vitamin D deficiency, less rickets up there than there is when we go down further south to around the Mediterranean. Why? Well, at least in part, has to do with fascination that they have with taking cod liver oil. And when they take cod liver oil, it was later found that it contains vitamin D. And 1 teaspoon of cod liver oil contains anywhere between 400 and 1,000 units of vitamin D, and that protects a lot of people from developing rickets. So realizing that there was this sunshine vitamin, realizing that there was this stuff that they had just recently discovered as vitamin D, they said that let's fortify the food. So in the late 1920s, early 1930s, the food was fortified. And the food was fortified, and then rickets almost completely disappeared in the United States and the rest of North America and Europe. It's just basically unheard of. And how do you get the vitamin D? Well, you fortify the food, and you fortify the food, or get the kids out in the sun. And if you're going to fortify the food, you take some of the yeast that's been irradiated, or if you're going to fortify the food, you could take some of the sheep's wool or some of this chemical called the 7-dehydrocholesterol from the skin, and you can irradiate it and then put it in the food. That's what a supplement is. Do we have rickets today? Well, a little bit, but not very much. And we have basically that occurs in black children who've been breastfed exclusively, and typically they're less than about 30 months of age. How do we make the diagnosis of rickets? Well, rickets is made by an X-ray that shows some changes in the bones, what we call the ricketic rosary, or kids who are knock-kneed, or people who have bow legs, or people who have enlargement of the growth plates of the bone, maybe in the wrists, the ankles, maybe in the ribs, or the area where the rib and the bone meet at the breastbone. We find that some of these on X-ray have some frontal bossing, enlarged head, or they can have subtle pain in the bones, or they can have delayed ability to stand because the bones are weak, and when they stand they frequently fall, and delayed growth. And we can find that at least some of them, because they don't have enough vitamin D, so they can't absorb the calcium, and they don't have enough calcium in the bone to serve as a reservoir, so some of them can develop tetany typically before age 1, and a delay in the tooth eruption. We can sort of confirm the diagnosis with some laboratory tests. We know that there are several different kinds of genetic abnormalities that can lead to rickets. So remember we talked about those different kinds of enzymes. Well, we know that you can have a defect in the enzyme in the kidney, so you can't manufacture that 1,25-dihydroxy vitamin D, the active form of vitamin D, and that can cause one form of rickets. It's a genetically transmitted condition, and we call it autosomal recessive disease. We know there's another form of rickets where it isn't the enzyme in the kidney, but it's a vitamin D receptor. And for that particular kind, then we have a different sort of issue. In the first kind of disease that we talked about, well, it isn't giving the calcium that's the issue. It's getting that enzyme that we have to do. So if we look at the tropics right now, if you have rickets, chances are it's going to be a deficiency in the calcium intake, because they theoretically get a lot of sun down in the tropics. And in the United States, probably only about 1 in 4, and in Canada about 1 in 4, and in Europe about 1 in 4 of the people with rickets going to have it as a result of a defect or a diminished amount of vitamin D in the system. The rest of them going to have it as a result of too little calcium in the system. And then there's a sister disease to rickets, and that's another classic as far as vitamin D is concerned. And if you don't have enough vitamin D as an adult, you could develop something called osteomalacia. Now, the bones have already formed, so that's not an issue like it is in the kids. You don't get the deformities of your bone, but you do have a problem with pain. And you get pain that's present, sort of a diffuse pain in your bones, and you can tell that you have the pain by pushing on your breastbone or by pushing on the front of your lower leg bone. And if you do that, you're going to get some pain. Now, it's oftentimes confused with arthritis, but arthritis is pain in the joint, not pain in the bone. And some people have this fibromyalgia that's considered pain all over the joint. And that's a disease or not a disease. We won't talk about that now. But suffice it to say that when you have the pain on the bone itself, when you push your finger in the bone, that's because you have a lot of sensory nerves just under the periosteum, that's the coat just right around the bone, and that's where you get some hydration of some of the newly formed matrix that doesn't have any calcium in it, and that seems to be associated with the pain. So we make the diagnosis with a couple x-rays where we see some pseudo-fractures that can occur in the pelvis or can occur in the scapula, your bone in the back of your shoulder, and as a result, we know that we have a condition that is relatively uncommon. So we're talking about vitamin D metabolism. We say vitamin D metabolism is important for bone, and here are the two classics of vitamin D, a deficiency in vitamin D, and we said that they're very rare nowadays. I dare say none of you who are watching the show have seen a case of rickets. None of you are aware of anyone with osteomalacia. But those are the kind of diseases that we see in vitamin D deficiency. Instead, we say that probably 50% or up to 100% of the people are deficient. That's why it doesn't make any sense. Osteoporosis, does that have to do with vitamin D deficiency? Come on. We know that an awful lot of people have what we call osteoporosis, and again, we're using numbers that are sort of made up, but there are about 40 million people in the United States. They don't have any of the bone pain. We say that probably somewhere around a third of women between 60 and 70 are going to have osteoporosis. We say probably somewhere around 2/3 of the women over age 80 are going to have osteoporosis. The likelihood of a fracture, if you happen to be a woman, an osteoporotic fracture in the course of your life is probably around 50%. If you're a man, it's probably around 25%. It's associated with a low level of bone mineral density. Your bones seem to be not that they're poorly formed, just that the cells aren't calcified appropriately. But there's a lot more to osteoporosis that than it has to do just with the amount of calcium in your bone. It has to do with the internal structure of your bone, and how that relates to a deficiency in vitamin D, as I said, is very difficult to say, simply because we know that if we give people vitamin D, and they did that in the Women's Health Initiative, they gave the people the vitamin D, and it didn't seem to make all that much difference. If you take the vitamin D, you're going to get more kidney stones. Yeah, that's true. But what about reduction in the incidence of osteoporotic fractures? Didn't happen. So now what we're left with is, what is the effect of vitamin D on other areas of the body unrelated to the bones? And is that something we really know anything about, or is it something that people are just blowing a lot of smoke around? And we're going to discuss that when we come back. Thanks for watching. I'm Dr. Ken Landau.